First of all,
Thank you so
really
much.
thank
Thank
you
you
so much
so
for coming
much.
out. Especially if you were at meetings all day today, like many of us were. This is another commitment. So it really talks to us a lot about your commitment to the VAD community, to ICCAC, and to our progress moving forward. It is my great pleasure to introduce Dr. Peter Eckman, who will be our next speaker. One of the things that really intrigues me about that process, when I first got involved in VAD therapy, what I was thinking about in VAD therapy was not a problem. Once we put a VAD in somebody, heart failure is gone. We don't have to worry about it anymore. It's all done. That's why we put a VAD in them, right? And I'm not thinking BiVAD, I'm just thinking LVAD, because in my world, we only did LVADs about 95% of the time. But I have learned from Dr. Eckman and from the rest of my team a lot about the fact that heart failure continues, that neurohormonal response continues, and that we need to really make sure that we don't forget that in light of the fact that we have put a mechanical circulatory support device on the left side of the patient. Dr. Eckman did his training at the University of Minnesota, meaning his fellowship in cardiology, and then did advanced heart failure training at the Cleveland Clinic. We were lucky enough to get him back at the University of Minnesota, and I say that for two reasons. First of all, because he's the medical director of our MCS program, and second of all, because he gets what we do. So as an LVAD coordinator, when I at least play one on TV and have them on the path, the fact of the matter is that you really need to have a medical team that understands what we do, understands the breadth of what we do, and also understands the limitations. Dr. Eckman has been a leader for us. He's a leader in the community as it relates to VADs, well respected and well recognized, and we welcome him to our session tonight.
Thank you, Michael. Thank you. Is the mic on? Can you hear me okay? I'll shout at least. So thank you for the invitation. I'm really honored to be here tonight. I'm really lucky to work with people like Michael, and have Lee, who's one of our VAD coordinators, actually is our lead coordinator, and also Lisa, who's a clinical nurse specialist with us, and Tony, who's our research coordinator. And they make my job easy. I'm really lucky to have a great team to work with. So I am really grateful to be here tonight. There's two firsts for me here tonight. The first is I'm from Minnesota. I gotta be careful where I stand here. I'm gonna get feedback. I've never before given a talk outside. So, especially in April, although it's 70 degrees in Minneapolis today, so our long winter is over. And the second is that Tonya kept filling up my wine glass, so I've never given a talk before after having 2 glasses of wine. So hopefully I still remember what's on my slide. So we've got 2 firsts tonight. But again, thanks for the invitation. So next slide, please. In terms of disclosures, the key ones are that with both Diuretics and Heartware, I've done work with both companies, and we're a training site for Diuretics, and so our institution is compensated for that. Next slide. So when I see patients with heart failure, and I talk about heart failure in general, I like to present them with a model of that there's 3 parts to managing heart failure. The first is controlling congestion, and there's a lot of ways we do that. Diuretics, obviously our mainstay. Sodium restriction, we spend a lot of time talking to patients about how do you avoid sodium and how do you minimize your fluid intake so that you're making the behavioral and dietary changes that will help avoid congestion, which is really one of the key reasons people get hospitalized. So I think that's one of the biggest issues in terms of heart failure management, but that doesn't affect prognosis. And so then when we look at the neurohormonal therapy, that's where we get into the ACE inhibitor, beta blocker, aldosterone antagonist, and some patients vasodilators. That's part 2. Part 3 is sudden cardiac death prevention with defibrillators. And then part 4 is the advanced options, inotropes, VAD transplant. Doug Horstmanshoff from Integris in Oklahoma City talks about a toolbox, and the VADs are kind of the bottom of the toolbox. And I think it is important that we talk about this with patients when we first diagnose them. But VAD, even if we move to this, it doesn't necessarily solve all these other issues. Next slide, please. So when we're talking about heart failure in patients with ventricular assist devices, one of the things we obviously have to think about is whether or not this represents device thrombosis. And so for tonight, we're going to assume that that's not the problem, and that we're dealing with the fact that they still have underlying heart failure, but it's not something such as device thrombosis, which we obviously treat very differently. Next slide. So the question about pulsatility is an important one, and this comes up because the whole mainstay of treating heart failure is affecting the neurohormones. Aldosterone, angiotensin, renin, epinephrine. That's what we're doing with all these medications. And so what has been hypothesized for 40 plus years is when you put people on some sort of non-pulsatile device, what does that do to their neurohormonal status? And this is from a study that David Markham from UT Southwestern had done, looking at the neurohormones in patients with VADs, whether they were non-pulsatile or pulsatile. And the bottom part here is looking at their smooth muscle or musculoskeletal sympathetic tone. And you can see that patients with non-pulsatile VADs have an increased sympathetic tone. We also see that in the patients with continuous flow VADs, I may have misspoke, have a higher rate of some of these neurohormones. And so the fact that there's less pulsatility, we think has something to do with the level of these neurohormones. And if that's the pathophysiology of heart failure patients before they get a VAD, if they're having less pulsatility and that increases these neurohormones, that's also something that may portend worse prognosis from a heart failure standpoint. It also may improve the probability of recovery. Next slide, please. The other reason that we care about heart failure therapy or care about standard heart failure therapy in patients with VADs is recovery. This is not common, and I think this varies from program to program. Some of that depends on when you elect to implant VADs and how much time you spend struggling with medical therapy versus how much time you spend just going right to mechanical support. But the data, mostly, this is from a couple of studies from Emma Burks, who was at the Harefield, now is in Louisville. When they had patients that recovered, they treated them with very aggressive neurohormonal therapy. I mean, these are regimens that we would be happy with in patients with heart failure who do not have a VAD. Very high dose lisinopril, full dose lisinopril, high dose carvedilol, spironolactone, and an angiotensin receptor blocker. And they often, in some cases, at least in the initial study that they published in the New England Journal of Medicine, used digoxin, followed by clenbuterol. In Louisville, because clenbuterol is not available in this country, did not use that, but found that aggressive heart failure therapy was an important part of recovery. So especially in patients where you're trying to achieve recovery, blocking these neurohormones is really critical, and this is something that we want to focus on. And of the patients that we've seen that have had recovery, they have typically been on full dose neurohormonal therapy. So I think this is part of their course, especially if that's one of your goals after implanting mechanical circulatory support. Next slide, please. However, after people get VADs, we tend to not have them on as much of these therapies. And this is a publication from Dave Lanfear's group in Detroit, looking at the percentage of patients on these different medications after implant. Now, not surprisingly, milrinone use plummets. Sildenafil use goes up, trying to treat right ventricular failure. But many of these medications, digoxin, not surprisingly, goes down quite a bit. Spironolactone use goes down. Nitrates go down. This is a single center, and so their beta blocker use went up. I can tell you, I will admit, our beta blocker use after VAD, probably 50%, if even that. And I think a lot of that has to do with managing right ventricular failure, and people just don't seem to tolerate it. But I think this really highlights that there are changes in medications after VAD. I mean, this is something everyone in this room, or I guess not a room, this yard knows. And this is something that we clearly see on a daily basis. Next slide, please. So what's in the guidelines? I won't read this to you, but the ISHLT guidelines note that diuretics are useful, surprise. ACE or ARB may be used, beta blockers may be used, mineralocorticoid receptor antagonists may be used. This is very different than the general heart failure guidelines, where it's more along the lines of you really have to do this. And so after VAD, it's a lot more vague. And I think what's also notable is level of evidence is C in each of these cases, meaning we really don't have a lot of data on the use of these drugs after people get a VAD. Next slide. Digoxin may be useful. And then they didn't put this in the little bullet points, but they do say in the text, nitrates and hydralazine are also useful for after-load reduction for patients that can't tolerate these other drugs due to renal insufficiency or hyperkalemia. I have to admit, I am a big utilizer of hydralazine, for example. I think this is a very effective medication, especially in patients that we have concern about their renal functions. This is something we use a lot of. So the guidelines suggest that it's important that we continue their standard neurohormonal therapy, but they're the first to admit that the evidence for this is pretty marginal. Next slide. So when we go back to the framework, at least that I have for treating heart failure, which is diuretics, neurohormones, and sudden cardiac death prevention, the first question is diuretics. Now, one of the things that's really interesting is that this is a study looking at what happens to plasma renin activity, and this is one of the neurohormones that we're blocking with all these drugs. When you put people on diuretics, and this is something I'm sort of envious that of people that were doing studies 15 years ago, that you could get a study published with these kind of numbers, because I think that would be a challenge now. But what they found was that when you put people on diuretics, not surprisingly, it causes some degree of intravascular volume depletion. Your plasma renin level goes up. It has been argued, and if you go to the Heart Failure Society meeting, this is one of the things that gets talked about, is yes, diuretics are important for controlling congestion, but are they a double-edged sword? And are they causing more neurohormonal activation that we're then blocking with other medications? And if we had another way to control congestion independent of diuretics, that might be important. So in VAD patients, where most of you, or probably all of you have seen, they tend to need less diuretics. I think that's a good thing. And one of the things that I tend to do is say, well, if you're congested, we just put this, $90,000 pump in you. Let's use it. We've got the Maserati. Let's put it to use, as opposed to using the Lasix. And this is one of the pathophysiologic reasons that there may be some advantage to that, is that if you're doing this with the device rather than diuretics, you may not be causing as much of an increase in renin activity. Excuse me. Next slide. Or next, thank you. Just one more. So some of the things that we have seen in retrospective studies suggest that diuretics may actually increase mortality. This is an association, and the counter argument to this is that sicker patients need more diuretics, so I think that the jury is far from out on this. But it's one of the concepts that I think does come to play when we're managing VAD patients. Next slide. So when patients have diuretic resistance, we're lucky. If they've got a ventricular assist device, that's a whole other tool that we have to try to help manage that. And often diuretic resistance may have been a trigger for them to be referred to your program, to be considered for VAD in the first place. Once it's there, that's a great way to manage congestion. Other things that we can do in this, all these other tricks come from standard heart failure therapy. They still apply to VAD patients. You can still use the other diuretics that have better oral absorption. You can still use thiazides. You can still use aldosterone antagonists. And there is data on ultrafiltration in ventricular assist devices, and there have also been reports of both peritoneal and hemodialysis is now becoming, I don't want to say common, but at least is present. Whereas 5 years ago, this was sort of a, wow, if you found a dialysis center that would take a VAD patient 5 years ago, you'd be in the plenary session at this meeting. Whereas now it's kind of everyone sort of, oh yeah, we've got one of those. Next slide, please. So in general with heart failure, when we talk about when to use ACE inhibitors, there's a lot of data on routine heart failure patients, people with a low ejection fraction. This is very well established in terms of a mortality benefit. What we tend to do with VAD patients is we try to continue this, but it doesn't always work. Next slide. I think the more important question, especially after people get mechanical support, is when do you stop the ACE inhibitors or the angiotensin receptor blockers? And some of these factors are more operative after people get a device than they are before. I took some of this from a slide that I have used when I've given talks on heart failure to primary physicians, for example, where I spend a lot of time convincing people, please don't stop the ACE inhibitor. But I think that this is something that in VAD patients is a little bit different, but I think we still need to go back to the basics of, in many cases, and there was a patient that Lisa had seen just last week who was on bumetanide, and we've been having to decrease him because he's been hypovolemic. He's getting lightheaded when he stands up. That's not necessarily a lisinopril problem. If you don't need the diuretics, back off the diuretics first. avoiding nonsteroidals, for example. I love to blame other specialties. I'm a cardiologist, so it's never my problem. It's the urologist. You need to be on your prostate medication. So look for other reasons. I think really the key thing is intractable symptomatic hypotension. And in VAD patients, especially because it's so hard to measure their blood pressure, we're often left with a symptomatic or a subjective report of when they're hypotensive or when they really just can't tolerate these medications. This is a very common reason. I bet 30 to 50% of our patients can't tolerate these medications due to symptomatic hypotension, lightheadedness, etc. The other thing, and I meant as I was on the plane today, I was reading and sort of thinking about this, and I meant to change this and I forgot. I probably should say a GFR less than 30 rather than using creatinine per se, but I think that's a level below which I start to get nervous about using ACE inhibitors unless there's a compelling indication. Diabetes with proteinuria is probably the best example, and even then I like, I'm the first to admit I like to have the note from the nephrologist saying, yes, I think this is important, you should continue the ACE inhibitor even though they've got diabetes and creatinine of 2.8 because I think that's a good idea. So even I get nervous about that. Next slide. Hypertension management, this is not news to this group. This is a big part of what we do in managing VAD patients. The goals from the guidelines are a systolic pressure less than 130 or a mean pressure less than 80. This is hard, is my take. And a lot of this is I almost never have as much confidence in the blood pressure measurements in VAD patients as I do in general heart failure patients where they've got pulsatile blood flow. So we target this, but I feel like we have to very often take this with a grain of salt and we're left with what they will symptomatically tolerate. Next slide. There have been a couple of studies looking at blood pressure, and this group certainly, I think, knows this very well. This was a study looking at using a Doppler versus the Terumo Elimano versus a Dynamap. They took 30 inpatients, 30 outpatients, all with HeartMate 2, found that the Doppler always worked, the Terumo almost always worked, and the Dynamap worked about 2/3 of the time. Found that the Doppler better reflected the systolic pressure rather than the MAP, and this is a little different than what some other studies have found. This is a little bigger group, but still, when you compare this to a study of hypertension management where they study 10,000 patients, this is still, we're dealing with very small sample sizes, and so you, to some degree, are left managing people based on their specific characteristics. But I think, to me, the most important sentence of this whole paper was titrating to a Doppler blood pressure of 70 to 80 may produce adverse effects. And the issue there is that very often this may not be their mean pressure. This may be their systolic pressure. So you always have to take this with a grain of salt. And this really fits my experience when people with, if I thought that a Doppler pressure of 85 was a mean pressure and I try to add that ACE inhibitor, a lot of these patients don't tolerate this. So maybe this is just me making excuses of why my use of antagonists in heart failure patients with VADs is marginal, but I think this really reflects what we're seeing in practice, which is to say that they really don't necessarily tolerate these medications. Next, please. In terms of beta blockers, again, the second component of neurohormonal therapy, there's a lot of studies and a lot of data suggesting that this, well, not just suggesting, I would say proving that this is effective in patients with heart failure. The patients with contraindications, asthma, that's got to be pretty significant. Conduction disturbance, almost all these patients have devices, or I should say electrophysiologic devices, so this is rarely a contraindication in VAD patients. And it's also suggested to not start this when patients have volume overload. The biggest issue in my perspective from VAD patients is right ventricular failure. And so we end up with a high percentage of patients that are not on beta blockers after VAD because they just don't tolerate it from their RV function standpoint. So this is something that I think is a much bigger question and a much bigger issue after VAD, whereas in a general heart failure clinic, most patients can tolerate a beta blocker. Next slide. So with beta blockers, there's a lot of problems. I think everyone has seen this. Fatigue, bradycardia, it can make diabetes worse. There's some data suggesting that carvedilol may have less impact on glycemic control. And I just changed a patient the other day from metoprolol to carvedilol for that very reason. Reactive airway disease and COPD, there's some data, including from the Cochrane reviews, suggesting that their heart failure is so much better managed on beta blockers that their FEV1 is improved even on a beta blocker. So in most cases, it's still indicated. But the RV failure in VAD patients, that's really the biggest issue. And this really can occur late. And this may be a cause for needing to decrease or even stop this medication later. If we can get away with some of these other changes, they often will have low pulsatility. You may be able to get away with slowing down the pump speed, and that may improve RV function. And then you can continue the beta blocker. As this group also knows, a lot of these patients have significant ventricular arrhythmias. And so that's another reason that you want to continue these beta blockers if at all possible, because I have yet to meet a patient that enjoys getting ICD shocks. In terms of management, some of the other things you can do, RV failure really frustrated me as a fellow because, we don't have all the trials. We don't have merit and consensus and solved, and we can say, well, if you've got this, we need to put you on an ACE inhibitor or a beta blocker. After VAD, we're really stuck, or in RV failure, we're stuck. But if you go back to fundamental physiology and talk about preload, afterload, and contractility, you have the same tools and the same tricks to manage RV failure, which is much more common after VAD than it is in the sort of general heart failure population. And so that's where you're left with managing congestion with diuretics, trying to reduce afterload, whether it's phosphodiesterase inhibitors, other vasodilators like sildenafil, or nitrates and hydralazine, or contractility agents, digoxin, or even inotropes if you're really stuck. Next slide. Aldosterone antagonists have clearly been shown to improve cardiovascular outcomes in patients with heart failure, and so this is something that I have to plead guilty that I think I underutilize these. This is something that, as I look forward, I think I need to be more aggressive with this. It's also a great way to avoid need for gobbling handfuls of potassium pills, which that's another thing that no one has ever come to me and said, I love taking my potassium. Please, can I have some more potassium? Next slide, please. There are some caveats. I think this certainly still applies in VAD patients. After the RALS trial was published, which was one of the first to really establish the benefit of these aldosterone antagonists, there was a dramatic increase in hyperkalemia, and the admissions for hyperkalemia and in-hospital deaths associated with hyperkalemia took a big jump after this study became available. So if you're using aldosterone antagonists in these patients, it's really critical that you're following their potassium levels and that you're very aware of that in this patient population. Next. So vasodilators, in people that are intolerant to ACE inhibitors or ARBs, this is something you can use. I have very few VAD patients that tolerate these sorts of doses of vasodilators, although there's a guy that just left our rehab facility recently who's on this much vasodilator and still somewhat hypertensive. Sometimes that means that they're still congested. And the other population is African Americans. From the AHEF study, the fixed dose combination was shown to be of benefit. Again, this is not clear after VAD. How important is this that we continue? A couple more clicks, please. There'll be a quick Kaplan-Meier curve, and then we'll move to the next slide. One more click. The other part about heart failure, this is part 3, sudden cardiac death risk. In general, for patients with heart failure, what we're looking for is an ejection fraction less than 35%. Doesn't matter if they're ischemic or non-ischemic, and if someone has a life expectancy of less than 1 year, this is contraindicated. Next slide. It's a different story in VADs. And there have been 2 studies in the last year, one from Mount Sinai, the other from Columbia, looking at retrospectively the use of VADs the use of ICDs in patients with VADs. The first study looked at 106 patients with HeartMate 2. 67 of them had an ICD, which that's a little different than our practice. We're following about 110, and I think it's 103 or 104 have defibrillators. It's a much smaller group that do not. What they found was that a third of them had ventricular arrhythmias after VAD, but there did not appear to be an increased risk of mortality. Now, some of this may be that it's a smaller population. They just didn't see the difference because it was too small to see a change. They also found that a lot of these patients had appropriate shocks, but in people that had a VAD or didn't, there was not an association with improved survival. Another study looking at almost the same number of patients, most of whom had a VAD, found that the pre-op ventricular arrhythmias, meaning if you had VT before you got your VAD, these are the people that are going to have VT after they got their VAD. And nobody that left without an ICD died. And I would say that that tends to mirror my experience, or our program's experience, which is to say that people that come in with an initial acute infarct, maybe they spend a couple weeks in Dr. Albaniosi's ECMO unit being stabilized before we implant them, they often will tend to do well without a defibrillator. Next slide. One back, please. So this is a patient of ours, just as an example, 64-year-old man. He had a continuous flow VAD implanted in October of 2011 for dilated cardiomyopathy. He had a long hospitalization. I'm not proud of his length of stay, but we've all had these. In fact, the Diuretics users meeting is coming up, and there's the best case, worst case scenario, and a couple people on my team asked me, hey, what should we submit? And I said, Michael won with the worst case last year. I said, we cannot win worst case 2 years in a row. So this will not be our worst case, but this was not our shining example of success in terms of his length of stay. He had a lot of deconditioning, dysphagia, really didn't do well, but eventually got out of the hospital, had progressive kidney disease, eventually after a year and a half or so had a recurrence of his melanoma that had been thought to be in remission for several years. He showed up in the emergency department in April with ICD shocks. His blood pressure was pretty typical for a VAD patient. His PI is a little low. Creatinine really wasn't much different. And the emergency department called me. I still remember this call. I was driving in. I just dropped my kids off at school. I was about 3 or 4 blocks away. And they called me and said, well, he's having polymorphic VT. And I said, okay, sure, he sounds like he needs to come into the hospital. So I called our heart failure fellow and said, this patient's in the emergency department. Can you please go down and see him? And he calls me back about 5 minutes later. Next slide. And he said, he's in VF. And so this patient had actually been in ventricular fibrillation for 5 or 6 days, 94 hours. This is an LVAD alone. He had several sequences of ATP. Then he got 8 shocks at full output, and at that point, and this is something I didn't realize, the way his device was programmed is if you get 8 shocks at the full thing or the full output and it doesn't work, the device just says, I give up, that's all I can do. So the device stopped, which is good because otherwise it would have kept nailing him. And so he'd been in VF for about 5 or 6 days, and I think this was really interesting for me to see because we had a patient when I was a resident 10 years ago that had bivads that was in VF where we had, shut off the monitor because they were in VF constantly and it was just alarming and driving everybody crazy. Michael remembers this patient. And so we all feel like if they've got bivads, this is going to happen. But this can happen with LVADs too. And I think, to me, this was really a great example of how even if you have essentially ventricular standstill, if you've got a functioning LVAD, and his RV was marginal, so his RV was already working sort of as a conduit. I think if he had more preserved RV function, he wouldn't have tolerated this as well. But this, to me, is a great example of why patients with VADs are not necessarily at risk of dying from going into life-threatening ventricular arrhythmias. Next slide. And so he ultimately elected, we talked about cardioversion, trying to get him out of this, and he said, you know what, I'm not interested, let's just turn off my device. And he was kind of at that point anyway, he was struggling, and so he actually ended up withdrawing support. The other part of electrical therapy that I want to talk about is biventricular pacing, and I get asked about this a lot. So someone's got a VAD, the surgeon calls me and says, Peter, I've got a confession to make. The surgery went well, there's not much bleeding, he's not on many pressors, but I had to cut the CRT lead. And part of me, oh, come on, why are you so lazy? Why can't you just, get a retractor? Don't you have a med student to hold that out of the way? But often, surgically, it makes sense to cut it, or it's just something that needs to happen in the course of the procedure. And so there's 5 to 10% of patients who have their CRT disrupted in the course of their implant. In general, CRT is important. We think that it improves myocardial oxygen demand. and is of great benefit to patients with heart failure. But we don't know how important this is after VAD. Next slide, please. So this slide is something that I presented at Heart Failure Society about 3 or 4 years, well, probably 4 years ago now, that came from an argument that I had with the surgical fellow when I was a heart failure fellow at the Cleveland Clinic, where a patient had their LV lead cut, and he said, "Can you call AP to have him fix this?" And I said, "Why do you care? We now put in an LVAD. Who cares what the LV is doing?" And he said, "Well, what about the RV function?" And I said, as much as I am loath to admit it, you as a surgeon have made a good point. I will accept that that was a very good argument, and you're right, I might be wrong. So what we did, and this was very few patients, about 6 patients, we looked at their invasive hemodynamics when they still had a PA catheter in place. So it's in the first 3-4 days after their VAD was placed, and said, let's turn on and off your LV lead and get an idea of acutely, does this make a difference? And what we found was that for the mean arterial pressure, central venous pressure, PA pressure, and cardiac output, in no case did it make a difference. Now, admittedly, 6 patients, this was only acute, and there are some patients where it did make a difference, where one of these patients, maybe this was spurious, but their cardiac output plummeted when we shut off their CRT. So even though we think of this as affecting the LV, the septum does play a role in right ventricular function. So it's conceivable that CRT still has a role after VAD, but I have to admit that the number of patients that have had their lead cut or dislodged that we have sent to go back to get their CRT reestablished, you've got to make a pretty good case to me to do this, partly based on this N of 6.
So the surgeon was wrong?
I would say that, I'm trying to think, what's a diplomatic response here? I would say that he agreed that the risks of reestablishing CRT may have been outweighed by the potential benefits, and that we elected to continue with a conservative management strategy. Next slide, please. So to summarize it, and I'm wrapping up here, a lot of the heart failure management after VAD is very similar to patients prior to VAD. Diuresis is often still needed, especially in the first several months. I think it's something that there's a lot of advantage to continuing the neurohormonal therapy. One of the things that I always look for is what's happening to their left ventricular size. If they're still dilating, that tells me that we are missing the boat. Either the VAD is insufficiently unloading the patient, or that we are insufficiently blocking these neurohormones. Especially in VAD patients, you have to start low and go slowly. And this is something that probably every couple of weeks I get a CC'd a note from Lisa, who's our nurse specialist, who sees these patients who she's had to cut back the ACE inhibitor that I started because I was too aggressive. So this is something that comes up a lot. One change at a time is really effective in these patients, or really helps, especially because I don't think you can totally trust the blood pressure. RV dysfunction is a big problem, and I think, I look at this as our RV failure rate is very low, but our beta blocker utilization rate is also very low. So I think these two go hand in hand. And just because someone has abnormal renal function doesn't mean that you necessarily shouldn't use their ACE or ARB. Next slide. I think that's it. And needless to say, I am one cog in a very large machine. I'm very grateful to be part of a program that's been around since 1995. I guess next year will be our 20-year anniversary, and really lucky to have the support and collaboration of people like Michael and Lee and Tony and Lisa and all of the other cardiologists and surgeons that we work with. So I'm really grateful again for the opportunity to discuss things with you tonight, and I can now say I've given a talk outside after 2 glasses of wine.
All right, do we have any questions for Dr. Eckman?
Yes.
So, for patients with IV pacing who do not have the LV lead interrupted, to pace or not to pace post-op LVAD if you don't have
If it's not interrupted, I leave it.
Okay.
But if it gets interrupted, you've got to convince me that it's worth the risk to go reestablish it. There may be some merit to this, and I was just talking to one of our fellows recently about continuing and extending this study to look both acutely, and I think a case could be made to, for example, randomize people that have been implanted who have an LV lead that's still working to turn it on or off. Because now that we've taken over the left ventricular function, it probably doesn't matter. I mean, I look at this as, from an angina standpoint, I mean, one of the benefits of CRT is that it decreases myocardial oxygen consumption quite a bit, but so do LVADs. I mean, I've seen, and you have too, people with unbelievable coronary disease. There's one guy, I'll never forget him, he had a 99% ramus, all the rest of his coronary arteries were shot. And we put a VAD in, and he's had no angina ever since. And the reason is his muscle's not doing any of the work. And I think some of that also applies to CRT. So I don't know what to do with these people, but I think it's a tough argument to make that they need to go spend another 3 hours in the EP lab trying to get that lead back in their CS, risk of wound infection, when you've taken over their LV. I just think it's a stretch.
We have one more question over
Yeah.
How is the settings of your ICD after LVAD implantation? Because we have it on a very low profile. Because we had already a few patients who were suffering from ventricular fibrillation, and it's really painful for those patients, and you just set it on a very, very low profile.
Low profile in the sense of that you had a low threshold to implant them with a defibrillator, or that you're...
No, the defibrillator.
Minimal settings.
The settings.
Oh,
Yes.
yes, that's, and I'm glad you brought that up. I could have commented on that too, that we have found that a lot of the patients that have LVADs, we need to change their ICD settings quite a bit because they often do tolerate the VT better. We have a higher threshold, so to speak, to want them to get shocks. But I think that's a whole nother area of maybe they don't need the shocks at all. And often they just present with, well, I don't feel very good. And part of my differential of someone calling saying I'm more tired or I'm retaining more fluid is, let's check your defibrillator. Maybe you're in VT for the last 4 days. But often getting shocks isn't going to help them. So we often are, we do alter our settings for the ICDs after implant. Okay, thank you.